I am Danielle Weidner. I'm the administrator with Interim Healthcare. I started with the agency in 1991. We were very, very small back then. We did primarily staffing facilities, supplemental staffing. All of our home care at the time were private pay to all the high society people over at the Broadmoor. And insurance companies wouldn't even pay for home care back in the day. So we've come a long way, and we'll talk about that as I go through this presentation. But just a little bit about Interim. We were established in 1966. We started in Chicago, and in 1974, the Ringling family opened the what was then Medical Personnel Pool here in Colorado Springs, and we have been in business since. We changed, I believe it was like 1995. We changed our name to Interim Healthcare. We became a corporation, and since then, the Ken and Sylvia Ringling, who originally bought the business, their son and daughter-in-law have taken over, and within the last few years, their son is now within our organization, learning the ropes to take over the reins one day and continue the work we're doing here in the community. So, home health care. I'm sorry, your name is Diane? Okay. Do you have experience with home care agencies? Sure. Mhm. We can. Mhm. Yep. Lives with the, yep. And you can have home care, home health care, as well as hospice at the same time, and we'll talk about that. And yes, we can go into facilities. It's a little tricky with payers sometimes, but we can talk about that more. But home care, back in the 90s, it was basically, 24/7 care being paid privately by the patient or their families to keep people out of nursing homes, convalescent homes. Back in the day, those are ugly words. They've come a long way since then, but people want to stay in their home. And so that's all we did in home care. There wasn't ever a mention about skilled nursing or physical therapy or occupational therapy coming in to provide care. I mean, that wasn't even on anybody's brains. And then one day, an insurance company by the name of QualMed said, "Hey, do you have a nurse that can go just give an insulin shot? We'll pay you X amount of money." And we're like, "What? Who's going to do that?" And so there it started. And so there's different verbiage, if you will, now. So skilled care is the department that I'm the administrator for. And so we service patients that need nursing therapy services. And then what we used to call our non-medical department is now home care. So skilled is home health care, and non-medical is home care. I'm still trying to wrap my brain around that because I want to keep calling us home care. But the home care are the caregivers that will go into the home and do homemaking services, and personal care workers, which are not certified or licensed with the state. They're there to assist with activities of daily living. They could go grocery shopping. They can take you to appointments. Just that little extra added help. Home health care we can do anything from short-term, getting people out of the hospital who just had a knee done and just needs that quick physical therapy before the next step, or we could go in long-term um, under some payers that allow that. And our goal would be to keep people out of long-term care in facilities. Um, so the home care team and home health care team that I employ are registered nurses, LPNs. So they're your skilled nurses, physical and occupational therapy, speech therapy, medical social services. We can help with supplies and durable medical equipment, as well as monitoring patient care and education. Education is huge when it comes to home health care, and we'll talk about that here in the benefits of home health care. Um, so what we want is, I know that I was going to be speaking to caregivers, is that we want family members to be family members. I'm about to go into this mix myself with the circle of life and bringing in my mother-in-law into our home. And my goal is to make sure that I can still be her daughter-in-law, and my husband can still be her son, and that we bring people in that can be her caregivers. And that really is a benefit to home care, whether you're in there for short-term or long-term care. And that education that home care agencies can really give those family members. Um, I don't know how to transfer her. I am not a nurse. I'm not a CNA. I am not a caregiver. So she doesn't walk. How am I need to learn how to get her from point A to point B without putting her on the floor. And that's where I'm going to rely on home care, is to educate me on what equipment do I need? How do I do these transfers? She has dementia. Can somebody teach me about dementia? When's a good time to bathe her? I don't want to do it when she's sundowning. I'm sure I'm going to get, arms flailing and all kinds of verbal nonsense. So can somebody help me with that? And that's where home care really becomes a benefit for families and caregivers, is to what what's the best route of care for your loved one in your home, and how do we keep everybody safe and everybody sane? Um, and so just learning those safety techniques, verbiage, if you will, um, and then cost effectiveness. I have a patient right now whose husband said, I am paying over $500 a day to keep my wife in a skilled nursing facility because we cannot bring her home yet. We are cheaper than $500 a day for the care she's getting. So we're going to go have a conversation today. So cost effectiveness is huge than a facility. They do have 24-hour care in a facility. I'm not knocking facilities at all. However, the cost can, depending on where you're at financially, the cost can be way too much, and home care might be a better option. The home care industry, like I said, in the early 90s, it was all private pay. Insurance companies were not paying for this at all. And we were a very, very, very tiny dot on the healthcare spectrum. And I think what they've learned now is, it's a lot cheaper to send in home health care than to have our patients go to the emergency room, have them sit in a hospital bed for days, just educating on chronic disease and, you know, um, getting them to walk again. Well, we can help transition them. And I have that on here, that the market size in 2023 for home care was $390 billion. And with an expectation to in 4 more years to rise to $515 billion. That is in the United States. The United States has the biggest home health care population in the world. And so why aging population, chronic disease. I mean, chronic disease is huge. Chronic disease meaning diabetes, um, congestive heart failure, um, COPD, all those things that we can't get rid of. We have to learn how to live with. And that's where home care comes in. It's key as far as education goes. Cost effectiveness, like we just talked about, it's a lot cheaper to put home care agencies in to a patient's home than have them sit at a hospital just to educate them on how to manage their COPD. And then COVID-19, patients and families were terrified to have their loved ones go into a facility for fear that they'll get sick, or worse, that the building gets shut down and you can't go in and see your loved one. And they're completely isolated from you, from the world. Um, we watched that all happen, and it was horrific. Seeing that in the senior community. So keeping people home, keeping them safe is where we want to be. So who pays for home health care? A lot of people pay for home health care now. And this is where I could really get on a soapbox, so scale me down if I need to. So, anywhere from Medicare and Medicaid to private pay and everything in between will pay for home care. It's what do you need in the home? How do you qualify? What are the criterias that a home care agency should be able to walk you through and figure that out? There are some payers that pay more for more services, they don't have quite as extensive criteria. Um, and that's what we'll talk about today. So everybody says Medicare. Medicare should pay for home care. Well, Medicare does pay for home care, but Medicare is probably one of the tightest regulated payers we have out there, along with Medicare Advantage plans. So Medicare has a criteria. You have to be under a physician's care. You have to have a skilled need. What's a skilled need? Skilled need is a RN, PT, OT, ST. You can utilize medical social work under Medicare. They can't stand alone in the home, or CNAs. Again, but CNAs, they can't stand alone in the home. You have to have a skilled need, typically caused by an acute change. So a patient had a fall. They went into the hospital, they fractured a hip, now they're coming home. There's your skilled need. They need nursing and therapy to help them transition back to a prior function of care. So that's where Medicare, it really kind of has a tight grip on what home care can and can't do. And they have to be homebound. That's the biggest thing. You will hear that with a lot of payers. Patient needs to be homebound. Homebound does not mean that the patient cannot leave their home ever while under the care of a home care agency. It means that they leave their home very infrequent and needs the assistance of somebody else. It's a taxing effort. They need one or more assistive devices. They need the help of somebody else to exit their home. That becomes home care or homebound, sorry. So what I would advise all caregivers is, and patients themselves, is, do you know what your insurance company pays for home care? Lucy, do you know? Okay. Yeah. Really, really important if you're about to go into this into the home health care realm. What does your insurance pay for? And you might be surprised. Home care or insurance companies are really starting to get on board, even with non-medical care. Um, so know what your insurance company is going to pay for, and know what their criterias are. Um, Discharge planners in a hospital or even a skilled nursing facility, they do know some about what a payer will pay and what those criterias are. But what I have learned is that they will give misinformation sometimes, especially when it comes to Medicare. I have patients call me saying, well, so-and-so at a hospital told me that Medicare will pay for 24-hour care. No, Medicare does not pay for 24-hour care. Medicare is an intermittent payer. They pay maybe up to 28 visits per week. And you really have that home care agency has to really document the need for those 28 visits a week. Typically, you might get 5 a week. And that could be all disciplines combined, depending on what your needs are. It is all medically needed to be medically necessary in order for a health care agency to bill Medicare.
Of course, he just, the doctor says, that Medicare is going to pay for it. So he called us, of course, he's calling all the neighbors, and I need this type of care in the home, pay for my Medicare. And every agency in town is saying, no, they don't pay for that, and he's saying, that it's not.
Mhm.
So get down, some regulation somewhere in the depths of Medicare where like Medicare is paying for continuous care somewhere for someone. And so he printed that up for us, and he's like, well, here it is right here in black and white in the Medicare regulations, this can happen. And like, sure enough, like it basically said, if it's medically necessary, you can have up to this much continuous care.
No.
I mean, we can touch that with.
Yeah.
Like,
And here's the reason why is because Medicare, the way that they reimburse home health agencies is they pay us per 60 days. Well, 30 days and then another 30 days if we need it. But it's a lump sum. So and it's all driven by that patient's diagnosis. So if that patient is bedbound and just needs a catheter change once a week, you might get $2,000 per 60 days. And that includes your supplies because a home care agency is required to supply all supplies when you are billing Medicare. And so if you have a patient that has wounds and it's horribly expensive to dress wounds, you don't want that patient that's going to be a daily wound care, then a catheter care. And I mean, we've had some come on that have a brand new colostomy. So all the supplies that home care agency is paying for and has to pay their personnel and overhead on that $2,000 a month because we're paid episodically. So to answer your question, typically you will not find a home care agency that is going to take a continuous care patient because they're not going to get reimbursed. They're actually going to pay to take care of this patient. And that's where families, I mean, they're like, Medicare says that it pays for this. Why aren't you going to come in and take care of my loved one? Well, most home health care agencies are for profit. We're not nonprofit. And so we can't go in and give somebody their insulin 3 times a day under a straight Medicare payer for 60 days. We're gonna eat up that $2,000 in about a week and a half, depending on how much you pay your nurse. So it's checks and balances, and depending on the home care agency, some take them, but most of them won't. So, okay. So Medicare. So Medicare does, and every year we get our little thing saying, oh, you are going to get a pay cut. And now we're going to pay you based on your outcomes and things like that. So home care agencies have to play very, very clean with Medicare in order for it to be profitable for them and to provide the appropriate care for that patient. Medicaid. Medicaid is there's ways that we can do that continuous care. Medicaid doesn't hold us to quite the same standards as Medicare. And I always say that there's 100 different buckets in Medicaid. And I will be the first to admit I do not know all the buckets, I know the two buckets I put. That's acute and long term. So, so we have a patient that'll go into the hospital to have a acute change, and they've fallen, they've broken a hip or whatever the case may be. They do have Medicaid. They don't have another payer. Medicaid, I always educate my patients that Medicaid is the last payer of resort. So if you have a commercial insurance, if you have Medicare and you meet that criteria, we're billing all that first. And then if we need to, we're going to bill Medicaid. But they go in, they break a hip, they come out, they need therapy. That's an acute change. We can see that patient for up to 60 days, hopefully shorter, where we can get them to a point where they can now go to outpatient therapy. They can go to the wound care center, or they're doing a lot better and they can start doing their own care on their own. They don't have to be homebound with Medicaid. And so that's a big thing for, I would say, the younger population. Um, and but in an acute setting, there's not too many times I run into a patient who's not homebound. They typically are homebound in that acute change. And so they still kind of fall into that same criteria as Medicare, but they don't have Medicare. Long-term care, I love long-term care. People move to Colorado for long-term care. Met quite a few over the last week as I've been talking to patients. So another bucket of money, and they qualify for long-term care. Basically, they're almost at a nursing home level of care, but their care can be provided in the home. And I've had patients on long-term Medicaid from birth all up into, I think we have patients now that are 26. They've been with us the entire time with Interim Healthcare. And they can have parents that do their care. They have our CNAs go in and do their care. They don't have to have the same criteria as Medicare, where you have to have a skill involved in order to have custodial care, to have CNAs. So we have what we call CNA only cases, where the patient just needs help with their activities of daily living. They have a diagnosis, say, of MS. And if it weren't for a home care agency, that they would be in bed all day long. How are they getting fed? How are they getting bathed? How are they getting clean? Who's helping them with their light housekeeping? So we go in sometimes 3 times a day and we get them up, we get them ready for the day. We get them in their wheelchair where they can be mobile now. We go in the afternoon, we help them with midday care. They go back at night and we do it all the opposite, and we put them to bed and until the next morning. And that's every single day. Keeps them in their home. Some of them even go out to day programs. Some of them even have jobs, I think more volunteer jobs. And they get out and they lead a normal life, but they just need us to come in and help them. They don't need to be in a facility. And so it's a great piece of Medicaid. There's 100 different waivers. I know in our non-medical department, we service a lot of IHSS patients as well as HCBS patients. Those are all waivers, depending on where they fall in the criteria. If they qualify for that bucket of money, then it all depends on, and then you get the care based on the waivers you're under. Medicaid is a beast, and that's why you have people like Lucy and Jen to help you navigate that, because Medicaid is so big. I only scratch the surface of it, of what I know under home care. So if you have any questions, please reach out to the Pikes Peak Area on Aging or DHS, whomever, somebody that can help you, the Resource Exchange. those people can help you. Sometimes agencies have a social worker that can really walk you through that. There's companies like Beneficent that can help you walk through that. There's resources out there. You just got to ask for them. Long-term insurance. This is a plan that you started paying for a long time ago, hopefully, and you've been paying into this plan, and now you need it. And so, long-term insurance companies, they're not huge as far as the population's knowledge, but they're out there, and they do save the day. My mother-in-law, thank God, has a insurance policy. And her financial advisor set them up with it years and years ago. And such a blessing. So long, depending on the plan that you
Yeah. I help it was, so to come back and sit down and go, okay, we're not gonna know. We're gonna do this, we're gonna do this. I.
yeah, it's really a great investment. And it is an investment. So long-term insurances will they'll pay for your care depending on your policy that you choose. It can even include a death benefit. But they will pay up to a certain amount of money per day. And you have to qualify. Again, there's qualifying factors. The biggest one is depending on the policy you sign up for, there's an elimination period. It's typically about 90 days that you have to pay out of pocket for the first 90 days. Then when you hit that 90 days, then your long-term policy should kick in. There are going to be criteria depending on the company you're with. So typically they have you have to have failed on 2 or 3 ADLs out of 6. So you can't bathe yourself, you can't dress yourself, you can't feed yourself, you can't walk by yourself, whatever the case may be. They have you go through this huge interview process with the nurse. Why is it that you can't do these things, to make sure that you're just, not wanting to collect your $250 a day. They will not only pay for your home care if you're still remaining in the home, but they will, if you're not in a home, they will actually pay for an assisted living, some policies. So really know the policy that you're signing up for, because those are key things. Will they pay for home care? Does the home care agency have to be a Medicare certified agency or a state licensed agency? Some insurance policies do require that, some do not. So, so make sure you know what that rule is. Know your elimination period, and then know how much you get per day. And then the per day it should not change. I haven't seen it change from home care to an ALF. So if you get $250 a day, you get $250 a day. So, pardon me? Per month. Okay, and again, all of them will change, or will be different, not change, but be different. And the other thing they do is, again, depending on what you signed up for, it'll be capped at like $100,000 or $200,000. So once you go through all that money, then your policy ends. It won't take long. You're right. So again, know your policies and what the criteria are, and the stop gaps. VA is another beast. I don't claim to be an expert. All I could tell you on the VA is that you have to go through the VA for home care to pay. So you might have TRICARE and you may see a community provider. So Dr. Smith is a community provider. He will bill your TRICARE. He cannot refer home care for you to be paid through the VA. The way that happens is that you have to go to the VA, you have to be hooked up with one of their providers send the referral over to their home care department. That home care department will, based on your condition, your history, will decide how many hours you are allotted, what kind of services you get, and they will send that to a home care agency with the hours and authorization already in hand. That will not happen directly from a hospital or a community doctor.
The VA,
Mhm.
they're not medical, but I found out they have a medical license.
Mhm.
So if every VA place has to have a medical component to it, would you get? Or is it still just the APL?
So what they require is, so if you have a patient who just needs CNA care 6 hours a week, they always add RN supervision. So First Light isn't a Medicare certified agency, but I know for a fact they have an RN on staff that will do those supervisory visits. So yeah, they have to fall into some kind of criteria when it comes to that.
Care, I would nurse.
If that's what it says on their paperwork.
So
Mhm.
that is connect.
That could change.
It could be that they have a care plan without those people.
Mhm.
But that's counterfeit, I know, right, they're out. We can do.
Yeah, I mean, um, our non-medical department does not, well, they do take VA patients, but they ride on my A license. Um, so I don't know if it's all based on licensure, how that works. So, all I know is I get those referrals directly from the VA. If the hospital calls and says, hey, I have a patient that has TRICARE and they're gonna go through VA auth, I'm like, then you gotta send it to the VA. You can't give it directly to me. They won't even if I were to send that information to the VA says, we're not gonna take that from you to send them to the VA provider. So,
As a veteran and who has to go through that process to get anything authorized, there's another application that you have to fill out for your doctor, the extended services. And then from extended services, that'll decide if it's home care, if it's homemaker services. It's pretty much everything that like Medicaid and Medicare would cover. But the VA is the VA. So yeah, even with the power of attorney, you have to have a VA power of attorney before they'll do anything.
yeah.
Um,
That's great information. There's a lot of hoops to go through with the VA. And I know there's a lot of frustrations, but when you're in there, you're in there. And there's so many services that they can help you.
I was gonna say also, you could even have your provider ask for increased hours. So like, not a good example, but the VA pays for massage therapy.
Oh,
And so you get 12 visits a year. However, if your massage therapist believes that you need more, they can request more services. So that's how I get more additional visits is your healthcare, the provider in the community has to put that in there. And I always tell people just keep hounding them because the more you hound them on the secure messaging and calling them, then the more they realize that you do need those services because when people don't hound the VA, they just assume they don't need anything.
yeah.
But they can request more. And then the town halls, there's always the VA town hall calls where they will have medical providers on the phone answering questions from veterans.
Oh, great.
Yeah. And that's how I found out about massage therapy.
Oh, nice. Yeah, our social workers, they are really clued into Medicaid and VA. I just kind of hand that all off to them because, like I said, there's just so much information out there that I am just nowhere near to be a subject matter expert on that. I know how to bill them. I know what the criteria is to bill them. Yeah. Right.
That everything has to, like, be disputed or go through, there being decisions like that, it stops the madness for a lot of people. You know what I mean, like, it's really happening, if you're a caregiver, like, you have to go through the VA, like, even if, you know, lost an arm in a war, but you're not gonna get services unless you have a gun.
Mhm.
So they're not willing to go to the VA, then this is the.
Yeah. And I do hear a lot, well, I don't want to have my primary care doc at the VA because they change so much. Well, you got to pick one. I get that. It doesn't mean Dr. Smith can't still be involved in your care. It just,
So the VA have been through the, I forget which one it was, but the community care network. So if you can't get into a provider within 30 days, then they can send you to the community. So if you can't get in for primary care, you can ask to be seen out in the community, and perhaps it could be your community provider. That might be a loophole to get to use. Um,
I've heard some people are being told to go up to Denver if they need to be seen right away, like
yeah,
more.
what they can request
mental
though
health center.
also. So yeah, so like I have a VA in Pueblo that's literally 5 minutes from my house, but that VA doesn't offer a lot of specialty care. So a lot of my main provider is here in Colorado Springs. And then for specialty care, they can send you to Denver VA, but if you don't have transportation to get there, if you don't have resources pretty much, you can always request lodging. So they can put you up in a hotel room the night before if you have an
Oh,
early morning
wow.
appointment.
Okay.
You got to request it through the community care network. You have to request lodging. It has to be approved before you do it. You can request transportation and they can get transportation services to you so you can get to and from your appointments. You can, there's lots of clinics. There's one in Golden for like psychiatric.
Let's go to Golden.
They wanted a 7 o'clock appointment and I live in Pueblo, so I went up the night before, but didn't know I could ask for lodging. But it's just really pushing your provider to advocate on your behalf and knowing that as a veteran, if you cannot get in and seen within a reasonable amount of time, you can request to be seen out in the community because I can't remember which law it was that passed that to where the veterans can make their own decisions on that. But yeah, no, you can always just request to be seen out in community and then go through community care network. Yeah.
I mean, even for me to tell my patients, they're losing their minds because I can't get in to see a doctor. So that's good. Okay. Look, I learned something new today. Okay. Commercial insurances. So, again, so your Kaiser's, Blue Cross, Humana, I mean, most of them all have a Medicare Advantage. Did I go through Medicare Advantage yet? I didn't, which I can. But commercial insurances are very tricky. The home care agency has to be contracted with that commercial insurance, and you really, really need to know what your policy says for home health care. There are, if you sign up for a home care agency, they come to your home, they're going to talk to you about deductibles. They're going to talk to you about co-insurance. They're going to talk to you about co-pays, stop loss, all these words, the typical community does not understand. So we know what a deductible is, most of us, if we have commercial insurance. I don't know, I have to pay that before they pay anything. But depending on your plan, you might have to pay even more before home care is covered at 100%. So that's your out of pocket. And does your insurance company, do they pay a copay? Or do they pay, or are you responsible for a copay? Or are you responsible for a co-insurance every time a clinician walks through your door? So copay, meaning just like when you go to the doctors, I got to pay $30 every time I see my doctor. Well, a copay, every time a clinician walks through your door, it's $30. And if you have PT, OT, SD, and MSW, CNA, and you have 10 visits a week, that's going to get pretty pricey if you haven't met your out of pocket, your deductible, or anything like that. So really, really important that you know what your insurance home healthcare benefit is. And one of the things that has become a thorn in just about every home care agency side is authorization. Um, there's maybe 2 insurance companies we're contracted with that we do not need authorization. The rest all do. And you have to fight for that authorization, especially if you have been in a rehab prior to home care. Because they're going to think, well, you should already be at a point where you can walk and talk and eat on your own. Sometimes that's not the case. I mean, we have a patient right now who rehab sent her home because she's non-weight bearing. There's nothing more they can do for her. Non-weight bearing for 5 more weeks. Lives by herself. Fell twice before we even got out to see her within the first 24 hours. Like, she came home Thursday night. We were out there Friday afternoon. She'd already fallen twice. Lives by herself. What her issue was is she didn't know how to transfer in her own bathroom from the wheelchair to her commode. She fell in the bathtub. She got herself wedged in between the toilet and the bathtub and another fall. So I got on the phone and I fought with this insurance company saying, look, she's going to end up in the hospital. She's going to end up with another broken bone. You have to let us go in there daily right now to see her for CNAs, even though therapy hadn't been out there yet. And it was over the holiday weekend. It was over Labor Day. Give us 5 visits. Let us make sure she gets through the holiday, and then we can talk after that. And so they did. They gave it to us, but it's typically somebody understanding what the care is happening in the home, saying things like rehospitalization, continued injury. She's going to break another bone. She's going to end up back. You know, they don't want to pay. They don't want to pay an ER visit. So really fighting for that. And if you're a family caregiver, an advocate, or anything like that, again, know the policy, know the words to say to get those authorized. And there's so many insurance companies that are just denying right out of the gate. Like, we haven't even seen the patient yet and you've denied it. How do you know that they don't need home care unless we've actually gone in to evaluate? And we're not just seeing this with commercial insurances, we're seeing this with Medicare Advantage plans. And so where Medicare, we don't need authorization to come out and see you. If you meet all those criteria that you're homebound, you've had a face-to-face with your doctor, you got skilled need, we just go out, we care for you until you've reached your goals, and then we discharge. No office needed. Medicare Advantage plans, they hold a really, really tight grip on everything you do. So if you've just been in a skilled nursing facility or rehab, we're getting denials. Home care is being told, nope, they just came out of rehab, they should be fine. They could deny based on the fact that the notes that we sent from the facility, either a hospital or either a SNF, those notes weren't good enough to justify care. Well, let us go out there, let us lay eyes on the patient so we can tell you how they're doing in their own home and then make that judgment call. So some of those insurance companies are starting to come around and say, okay, we'll give you 1 visit to go and look and see if that patient really needs us. And oh my gosh, don't ever tell an insurance company you're a willing and able caregiver. You will get denied all the time. Okay, so you want to be the wife. You want, you know, yeah. So in the minute there's a willing and able caregiver to give a bath, they deny. So yeah, Medicare Advantage plans are getting harder and harder to play with, and a lot of well, and there's a lot of home care agencies that are capping how many they take. So I know at one point, because we were fighting so hard for payment on what services we already did with an insurance company, we capped them. We told the hospitals we'll take maybe 1 a week, if that. I know other home care agencies are doing the same things with different payers based on their contracts. So it's getting harder and harder to find agencies that could take your Medicare Advantage plans. Third-party liability, work comp, car insurance, homeowners insurance, another tough insurance to play with. Oh my gosh. They will put you through the ringer. And I'm not sure how other home care agencies are with this, but then they don't want to pay. Only fight for payment. So we are very picky at Interim about third-party liabilities. But no, and it's, sometimes your health insurance and your work comp, your health insurance will just pay, and then they will get together with work comp and they'll work out the money situation. But the minute that Medicare hears that your injury was because of a car accident, they're going to deny our claim, tell us to go bill State Farm. And that becomes a whole different ballgame too. Getting adjusters on the phone, getting typically they don't have a contract with home care agencies. They have a fee schedule. And the fee schedules, I think, were created in 1966. They're just, we'll pay you $5 for every 15 minutes that PT is out there. Yeah. So again, and they too have criteria. So you got to know with them too. Private pay, there really is no criteria. Private pay is, what do you like? Now, you still, so I was gonna say, we still have to go under regulation. So if you have a Medicare certified agency that is providing those cares under private pay, you still have to follow the guidelines of Medicare and Medicaid. So we need a physician order. So I have several private pay patients right now, and they will call me and say, because we'll have Susie going out every single day from 8 to 5. Well, the husband's going out of town, so now we need Mary going from 5 to 5 in the morning or whatever. I have to get a doctor's order for that. I just can't send out a caregiver because we do still have to follow the regulations of the federal and state government.
They don't have to use doctor's order.
Mhm. Well, so our non-medical is a B license. They do hang on to my A license, but they don't have to have they don't have to have doctor's orders.
They're not like.
Right.
So they can send a nurse out, got a doctor's order to go invest it in, dress the wound,
They should not be.
they could.
They could. I'd be really nervous about that because they're not regulated. I mean, the regulations for a certified agency are enormous, but they do keep you honest. And I just sat this Tuesday and Wednesday, I was up in Denver. I was sitting through a survey readiness conference, and I came home just going, oh my God, because we are so heavily regulated, like you can't even turn the wrong way before you have somebody at your door. So, and it's, it's all, these patients live by themselves. They're home alone. They don't know what we're supposed to do or not do. So, there's a lot of home care agencies out there with a lot of integrity, and, know your home care agency. And we'll talk about that here in a second. Who do you choose? And the regulations they do keep you honest. So government regulations. So Medicare certified agency, we have to comply with a variety of regulations and standards set by the federal and state government. So I have a binder in my office that's what we call them the conditions of participation, and they're the rules that Medicare has set forth for home care agencies. And then I have another binder that's titled state regulations, because Colorado came in right behind the feds and said, not only do you have to adhere to the federal regulations, but you're a licensed agency and now you have to adhere to all these state regulations. They're pretty much all the same, but Colorado put a little spin on about every fourth regulation. So just one little tiny spin that you got to keep, that you got to pay attention to and adhere to that. Patient rights and responsibilities, the federal government says every patient has rights and every patient has responsibilities. Okay, so we give everybody their patient rights and responsibilities. We educate on them. Well, then here comes the state and says, okay, yes, they have to have all these patient rights and responsibilities. But we also want the consumer to know who's paying for what. So we have to have them fill out another form. So it keeps you honest. The state is out at a home care agency that's licensed and certified every 36 months. And they go through everything. There's a gazillion things that they can go through, from the sign on your door, the hours that are posted, all the way to discharging a patient back into the community. So everything in between. Yeah. Yeah. So choosing a home care agency. So, yep. Funny that you should ask. Because I've done my research since my mother-in-law is in a memory care right now. And she's in their assisted living. And yes, they do all have regulations. I read the regulations. They're not as extensive as home care. But they do have their regs. They have to play by the rules as well. If you ever have any questions, I would call these ladies, call your ombudsmans, call the state if you have questions. They're all available to you online. I don't know that rule as a facility. I've never worked in a facility, so. But everything should be, yeah. A lot of it is public knowledge. So I know for home care agencies, any survey that we've been through, they're all online. They're for everybody to see. What we got a deficiency on, how we corrected it, how we did our next survey, etc. So all of that is out there for you to do your research. Mhm. Yeah, yeah. So choosing a home health care provider, experience is key. Being in a community for a long time for us has been key. When a new home care agency comes into town, I'm just like, oh my God, because what happens is that we will hear some of the things that they're saying in the community that aren't true. And so we have to go in and we have to fight with doctors and we have to fight with patients and say, no, here really are the regulations. Here are the rules that we have to adhere to. Range of services. So at Interim, we can, at one point in time, we were doing pediatric to the end of life. We can do peds and to skilled care, and then we refer out to hospice if needed. We have non-medical services, homemakers, personal care workers, CNAs, PTs, OTs, STs, RNs, social work. So if know the agency's ranges of services and hopefully that they meet your needs. Read about them. Go on their website. Go to Home Healthcare Compare. It's on cms.gov. You can put in like 3 different agencies. So you could put in Interim, Inhabit, Centura Home Care, and it will tell you how we compare to one another, how we are doing on our star ratings. So the government has forms that we fill out every time that we see a patient. They're called OASISes, and it's basically a comprehensive assessment of the patient. And here's where they were at the start of care. Here's where they were at discharge, and how did we do? and we get a star rating based on that. And home care agencies have to sign up with an outside vendor to do their patient satisfaction. So I can't just send stuff to Mr. Jones and Mr. Smith and Mr. Russell or whatever and get those all back and do my own tally. They have to go to an outside vendor. They ask, I think it's about 40 questions, and they send it back to that vendor. That vendor then sends it to CMS, and CMS gives us a star rating on that as well. So not only on our outcomes are we graded on, but we're also graded on our patient satisfaction scores. So that's all on Home Healthcare Compare. Know how your home care agency is bringing caregivers on. Are they vetted? Do they do drug screening, or do they do background checks? Do they have the experience you need? You certainly don't want a nurse going into your home on a trach patient when they've never done trachs before. You don't want a caregiver coming into your home when they're going to be there by themselves with your loved one when they have a background check that's 20 pages long. So you really want to know who the people are that are coming into your home. What's the cost? How much is the insurance going to pay versus how much you have to pay out of pocket? So do your homework there. And then how is the care coordinated and monitored? That's another thing. So who is going to oversee Susie that's taking care of your husband or your mom or your dad when you're at work? Who monitors Susie? So there should be a huge hierarchy of people that are over Susie who make sure that that person is providing the correct care, that is staying within professional boundaries. I mean, that your home now becomes their workspace. Are they respecting your home? Are they doing what the RN asked them to do? And if you need help choosing a home care agencies, you could talk to somebody here at Pikes Peak Area on Aging. You can speak to a social worker in the community. They've dealt with a lot of home care agencies. Or you can call me and I will help you pick one. So anyways, a lot of variety of home care, a lot of benefits to home care, both short-term, long-term, keeping people out of facilities. That's our goal. I'm not going to say we've never referred to a facility. At some point, people do need to go to a facility for safety reasons. But our goal is really to keep people at home. Our goal is to allow family caregivers to be family and kind of step out of that caregiving role. You get burnt out too quick. You need respite time. You need to be you too. So take care of yourselves. We'll take care of your family members. Any questions? Okay. All right. Well, thank you.